Hello everyone. Today we will be learning about assessment and management of patients with alterations in perfusion. So when there is alteration in perfusion, um, it's going to affect the Hello everyone, this is Professor George, and today we will be learning about assessment and management of patients with alterations in perfusion. So whenever there is a problem with perfusion, patients will have different types of vascular diseases. So today we are going to be looking mainly on peripheral vascular disease, which is a leading health concern, and it is an increasing incidence due to mainly obesity, diabetes, and we have a aging population. So it's approximate PVD affects approximately 8.5 million Americans. And about more than 200 million people around the world. Um, so peripheral vascular disease is uncommon in patients under 50 years of age, but increases in prevalence with age and affects a number of older adults. Um, you may see patients mainly in the hospital and nursing homes or home care setting, because that's where most of the patients may be staying or being admitted to the acute care hospital with the problems. You will be seeing these patients in the hospitals too. So it's important to have assessment to come up with the diagnosis, whether it is arterial problem or venous problem, and then come up with a plan of care. So vascular disease is again categorized either venous, arterial, or mixed. Most of the time it is either venous or arterial disease, because it can affect both the vein and the arteries. A differential assessment is essential to identify the type of PVD and plan management strategies. So venous dysfunction includes degrees of damage ranging from cosmetic concerns with spider veins or superficial varicosities to chronic venous ulcerations. Venous disease is more common in females and in older adults and those with a family history. Venous vascular disease accounts for 75% of lower extremity ulcerations. So you will really see like venous ulcerations on these patients with vascular disease or vascular insufficiency. Peripheral arterial disease is less frequent, and it is associated with increased patient morbidity. So it's more dangerous to have peripheral arterial disease. If arterial dysfunction is not recognized and tissues don't receive adequate oxygenation, the tissue death is certain. So the tissue can die without oxygen and nutrition. Peripheral arterial disease is most often secondary to atherosclerosis. Again, it is also seen in patients with diabetes, like high blood glucose level can lead to peripheral neuropathy, and that also can lead to skin breakdown because they may not have any sensation to the feet. Also, it can lead to poor wound healing and potential limb loss. So patients will end up in having amputation. Mixed venous and arterial insufficiency involves not only the sluggish venous return of the blood to the heart, but also arterial component where arterial damage decrease the blood flow. So in this situation, signs and symptoms of both venous and arterial compromise are observed. We'll be looking into risk factors, assessment, treatment, and nursing management. So the next slide includes the topic outcomes. We'll be looking briefly at the anatomy and physiology, the various diseases of the arteries and the veins, their causes, pathophysiological changes, clinical manifestations, management and prevention. We'll be looking at the most common venous disease, venous thromboembolism or DVT, in depth, and we'll be looking at patient education, how to prevent DVT and how to take care of either arterial or venous disease at home, including medications. So the next slide is about overview of the anatomy and physiology. We're talking about perfusion. So in order to have enough oxygen and nourishment to the body tissue, we need to have adequate perfusion. Again, the adequate perfusion depends on a properly functioning cardiovascular system. And adequate blood flow depends on an efficient pumping action of the heart, how efficiently the heart pumps. Sometimes the heart pumps weak or slow or sluggish because of different disease processes such as congestive heart failure. Also, the next one is patent and responsive blood vessels. So it is important to have patent or open blood vessels to have adequate blood to flow through it. So if there is blockage, then the flow will be disturbed or diminished. The next one is to have adequate circulating blood volume. Again, the factors that affect the rate and adequacy of the blood flow depends on nervous system activity, the blood viscosity, and metabolic needs of the tissue. Next is about the vascular system. This is again just an overview of the right side of the heart, left side of the heart, what the arteries does and what the veins does. So the right side of the heart pumps blood through lungs and pulmonary system. So the blood is going through the pulmonary artery into the lungs, and this is the deoxygenated blood. So the blood cells pick up fresh oxygen and it comes to the left side of the heart through the pulmonary veins into the left atrium to the left ventricle and into the circulation to the aorta and to the rest of the body. The arteries distribute the oxygenated blood from the left side of the heart to the tissues. These are the arteries, and the veins carry the deoxygenated blood from the tissues to the right side of the heart. So the difference between the artery and the vein, the walls of the veins are thinner and it is less muscular. The walls of the artery, they are thicker and it is composed of smooth muscles. So the arteries carry the blood to the extremities and rest of the body. Then the vein carry the deoxygenated blood from especially when it comes to peripheral vascular circulation is from the extremities into the heart. So you can see it, the veins have valves. We'll be looking at different venous disease. Sometimes the valves are dysfunction or not competent. That's when the patients will develop venous diseases. And you can see different layers of both artery and the vein. So we'll be looking at the circulatory insufficiency. So circulatory insufficiency or peripheral vascular disease can be different types. Again, as I said earlier, it could be either arterial disease or venous disease. And most of the time it affects the lower extremity more than the upper extremity. Um, most of the symptoms include pain. Patients may have pain. Then there will be skin changes. Pulses may be diminished or absent. There will be possible edema. Uh, Again, we will be looking at some slides that differentiate arterial and venous in all these symptoms. Like the pain will be different in arterial insufficiency. The skin will be different in venous disease. So we'll be comparing to see how we can differentiate whether it is arterial insufficiency or venous insufficiency. Again, these symptoms, severity of these symptoms depends on the type, like arteriovenous, the stage, whether it is like just starting stage or they are like kind of critical point, or the extent of the disease process, how far the disease has progressed, or the speed. Sometimes it can happen fast, especially if there is a occlusion, then these symptoms can develop faster. So this is actually a comparison of arterial versus venous insufficiency, the characteristics of pain, pulse, and the skin. So pain and arterial insufficiency patients will have, this is like classic symptoms or characteristics of pain in arterial disease is intermittent claudication. This sharp, unrelenting, and constant pain. Again, the severity of the pain depends on the where the disease process is, how bad the disease is. So in the beginning, they may have intermittent claudication, and it may get relieved once the patient rests. As the disease progresses, it can be unrelenting and constant pain. In terms of venous insufficiency, pain may be like patient may complain about like it's kind of achy pain, throbbing or cramping, kind of dull kind of pain. The pulses may be diminished or absent in arterial insufficiency. Remember, there is problem with blood going to the extremity. So if there is the blood is not flowing to the extremity, then there is no perfusion or circulation, so the pulse will be either diminished or absent, depends again on the blood flow. Here there is no problem blood getting into the extremities. The problem is blood getting back to the heart. So the pulses are present because there is circulation. It may be difficult to palpate because the patients will have swelling or edema to that extremity. Then looking at the skin and arterial insufficiency patients, the patients will have dependent rubor, meaning when you place the extremity or when patients sit on the side of the bed, for example, when they dangle their feet, the feet will turn kind of reddish color, and because the blood is going there. When you elevate that extremity turns pallor or pale because there is no blood going when you elevate that foot. Then the skin may be dry and shiny. Again, all this because there is insufficient blood flow or no blood flow. Um, Skin will be cool or cold to touch. There will be loss of hair over the toes and the dorsum of the foot, thickened and ridged nails. You can definitely see these in arterial insufficiency. And at the same time, we can compare in venous insufficiency where there is pigmentation in the gaiter area, which is the area of medial and the lateral malleolus. The skin will be tough and thickened. There will be reddish bluish coloration, and patient may have dermatitis, especially when they have this chronic venous insufficiency. The next slide is about assessment. So remember, your nursing process starts with the assessment. So when you get a patient with, some of these symptoms, you want to make sure, is it arterial disease or is it venous disease? So what are the signs and symptoms of peripheral arterial disease? So keep that in mind. We can differentiate what kind of disease the patient may have. So the patient may complain about, like, when you ask the patient, can you, describe me the pain? What kind of pain is it? They may say, it's like, muscular, it's cramp-like pain, discomfort, or fatigue in one extremity that occurs during exercise or activity, and it is relieved with rest. This is like typical, um, you know, symptom of arterial disease that is called the intermittent claudication. So it is intermittent. So the patient gets pain as they walk. It could be to the buttocks area or to the calf area, because those are the muscles like crying for oxygen. Because there is poor perfusion, the blood is not going through it, then the tissue or the muscles are not getting that oxygen. So it is like the muscles get really like painful. Um, so once they rest, the blood flow gets better. That's when the patient feels better, and the pain can be relieved and they feel better. So it's like intermittent claudication. It comes, and once they rest, it gets better. The skin can be pale, and the loss of hair, we looked at it, can be dry, scaly, cool to cold temperature. Thickened nails, peripheral pulses may be diminished or absent. When you do the physical assessment, you can actually do the inspection of the skin, and also you may see like pale extremity. When you touch the skin, you may feel like cold to cold temperature of that extremity. As you palpate on the pulses, it may be either diminished or absent. One thing to remember is whenever you do palpation of the pulses, make sure you palpate bilaterally at the same time, so you can compare both sides. If the disease is on one extremity, it can be either diminished or absent, while the other extremity may be healthy. You may feel a normal pulse. So make sure that you palpate the pulses bilaterally, either upper extremity or lower extremity, and then compare both sides. This is very important as nurses when we do assessment or palpation of the pulses. So these are like, taking history and physical, you're doing the physical assessment. Once we do that, we have to, confirm the diagnosis by doing certain diagnostic tests. These are like very basic diagnostic tests done. Um, one is the Doppler ultrasound, which is a continuous wave Doppler to detect the blood flow in the vessels. So most of the time we use the Doppler when we cannot actually reliably palpate the pulses. So Doppler will help us to detect the blood flow in that vessel. It's more useful when we combine the Doppler along with the ankle brachial index. So that is the NAST diagnostic test. Basically, ankle brachial index is, it allows us to actually quantify the degree of the stenosis or the narrowing of the vessel. So um, how bad is the stenosis or the narrowing. So you will know whether it is really bad, whether it is normal or there is mild to moderate insufficiency, or it is really like severely narrowed. So how do we do this? There is a YouTube video that is attached to here. You can watch that video. But basically it is, we take blood pressure on the ankle, and also the blood pressure on the upper extremity and the brachial artery. So we divide the ankle systolic blood pressure by the brachial systolic blood pressure. Um, for example, if the ankle systolic blood pressure is 120 and the brachial systolic blood pressure is 120, the ratio is like 120 over 120 equal to 1, which is normal. That means there is no arterial insufficiency. When the ankle brachial index is from zero point 0.5 to zero point 0.9, that means mild to moderate insufficiency. It could be when the ankle systolic blood pressure is 120 and the brachial systolic blood pressure may be like 80. So you see the ratio. So the more it get worse. So you can see how if it is less than 0.5, that means there is ischemic rest pain, and zero point 0.4 or less is like severe ischemia or tissue loss when really gets worse as the ratio goes down. So the next diagnostic test is the exercise testing, where we want to see how long the patient can walk, and then do the ankle systolic blood pressure in response to walking. So there should be no drop in the ankle systolic blood pressure after exercise. So the exercise can be either walking in the hallway or they can use the treadmill. Again, other diagnostic tests are duplex ultrasonograph. Again, this is a non-invasive test that evaluates the blood flow through the tissues, organs, arteries, and veins. It's more than a Doppler. It's a duplex ultrasonography, which is done in the ultrasound department in the hospitals or even outpatients. Then CT scan. Again, it gives more in-depth image of the tissues and areas of changes. So again, this is more, you know, better study like CT scan. Then Angiography also is done to confirm the diagnosis of occlusive arterial disease. Where in angiography there's the procedure includes injection of iodine or a radio opaque contrast into the arterial system. So since we are, since iodine is used to do this angiography, it is very important to ask the patient if they have any allergy to iodine or to shellfish. So if your patient have this allergy, make sure that you inform the physician or the radiologist who is doing the procedure. Um, it can be very dangerous if the patient have allergy and they use the dye. Then the next diagnostic test is magnetic resonance angiography or MRA. Again, it gives better image of the blood vessels, images of the arteries to evaluate them for stenosis, like how narrow it is, if there is any occlusion or if there is any abnormalities. Again, this is kind of, very in-depth study, and it really gives a lot of information with the MRA. Then venography is mainly for the venous system. So injection of the contrast or dye into the venous system. Patient should be monitored 2 hours after the testing, because we need to monitor the injection site or where they put the needle in or the catheter in, to make sure there is no oozing or hematoma after the procedure. So the patient should be monitored for 2 hours after the procedure. Some of the common arterial disorders are arteriosclerosis and atherosclerosis. Then the peripheral arterial occlusive disease, upper extremity occlusive disease, and arterial embolism, arterial thrombosis. So these are different arterial disorders. You will be learning different arterial disorders as you move forward in third and the fourth semesters. So these terms like arteriosclerosis, those terms you may hear it used interchangeably. So mainly the arteriosclerosis is when the arteries get hardened and the endothelial lining gets thicker, so you can see thick, kind of hardening and thickening of the inner lining of the arteries. In arteriosclerosis, the inner lining or the intimal layer gets accumulated with lipids or blood components like fat streak. You can see in the picture the fat streak, that is when the patients have arteriosclerosis. You can see this is clean one. Then here you can see fibrous tissue like plaque in here. Then this can be a complicated lesion where you can have thrombosis, calcification, ulceration, hemorrhage. So you can see how the blood flow is very limited because it's almost like clogged. There is, like, you can see a thrombus in there. So really how it is progressed with nothing, and then it kind of gets progressed. The peripheral vascular disease, how it mainly, like, we're talking about the upper and the lower extremity, but arteriosclerosis can happen different parts of the body wherever the arteries are. Like the common problems you may hear is like having a heart attack, a stroke, when it affects like the heart and the brain, and when it affects the peripheral vascular PAD, the patients can have a clot that just blocks the lower extremity, and the toes can get gangrenous because the blood supply is cut off. Then it can get gangrene because there is no blood supply going in there. Whenever the patients have like PVD or peripheral vascular disease or peripheral arterial disease, they may the chances of having arteriosclerosis of the heart, or having either coronary artery disease or carotid artery disease, or those things are very common because they can get clot or hardening of the arteries anywhere else in the body also. So what are some of the common site of atherosclerotic obstruction? So you can see it can happen, any of these um, arteries. Most of the time when it comes to peripheral vascular disease, you may see like obstruction happening to the like the femoral, the common iliac artery. Then it turns into like deep femoral artery here. So if there is like, then it goes into the popliteal artery. So they can get arteriosclerotic obstruction anywhere. You can get obstruction. Most of the time you may see in the femoral and the popliteal artery, because the common surgery you will see is the femoral popliteal bypass graft. So that is the most common surgery for peripheral arterial disease. We're going to look at a case study. So here the patient's name is Miss Smith. She's a 71 years old female. She came to the vascular triage service complaining about bilateral calf pain that was reproduced with exercise and elevated upon rest. So in this itself, you can see some of the topics we already discussed, how typical symptoms this patient have. Then we're also looking at the past medical history of hypertension, hyperlipidemia, social history of smoking 10 to 15 cigarettes per day, medications, lisinopril and amlodipine, and BMI was within normal parameters. So we're going to look at the risk factors that includes for both atherosclerosis and peripheral arterial disease. So when it comes to risk factors, most of the disease process you will see modifiable risk factors and non-modifiable risk factors. So modifiable is something that we can try to modify and get better, but non-modifiable we cannot modify it, like age, being female gender or family history or genetics we cannot change, but we can try to change these factors. So for example, some of the most common risk factor is nicotine use or smoking, uh, diet, like high in fat, hypertension, diabetes, hyperlipidemia, stress, sedentary lifestyle, elevated C-reactive protein or CRP, and hyperhomocystinemia. With nicotine use, what the nicotine does is it causes vasospasm, and it um, constrict the blood vessel and decrease the circulation. So we'll be reviewing the treatment, but at least know like how does, why is nicotine use put the patient at risk for having, PAD. So know that the nicotine causes vasospasm, which leads into, vasoconstriction and decreasing the circulation. The diet again could be like kind of high fat Western kind of diet. Um, then hypertension. So with especially when it is kind of uncontrolled hypertension, when patient already have like atherosclerotic lesions form in the high pressure, valves. So it could be in the peripheral arterial disease. Patients also can have coronary artery disease, and they can also have CVA or cerebral vascular accident or stroke. So hypertension is always a big risk factor. Then the diabetes mellitus, again, it can be uncontrolled just like hypertension. So uncontrolled diabetes, of course, the blood sugars are high, and there is risk for PAD when 2 to 4 fold, with amputation rate of 5 to 10 more in patients without diabetes. So there's a high risk of having amputation in patients with diabetes. So it's so important to really have the diabetes under control, the hypertension under control, so they don't really get, you know, um, diseases like PAD. Then hyperlipidemia, of course, there's high lipids. Um, then the stress, of course, with when patients are stressed, it it stimulates the sympathetic nervous system, and then it leads to peripheral vasoconstriction. Once it constrict, of course, it leads, it will lead to less or poor circulation. Sedentary lifestyle, like people who really don't do much exercise or walking or moving. Elevated C-reactive protein, or CRP. So CRP is it's one of the cardiovascular indicators. So it shows there is um, inflammation to the cardiovascular system. Once it is increased, it damages the vessels. So if there is elevated CRP level, that means there is inflammation in the cardiovascular system, and once there is inflammation, it will damage the vessels, and then it can lead into PAD. Next is the hyper homocystinemia. So this is homocysteine is a protein that promotes coagulation. So when it is increased, it can develop clots. So the higher or the more numbers of risk factors, the higher the chances of or the severity of the PAD. So if they have like 5 or 6 of these risk factors from the modifiable and 2 or 3 of the non-modifiable, there is high chances of patient getting PAD, and the severity may be even more. We're going to look at now signs and symptoms of arterial disorders. The pain, again, as we discussed earlier, intermittent claudication, remember what it is, a rest pain. So as the intermittent claudication progresses, or the PAD gets worse, patients will go into rest pain. That means the pain will continue even with rest. Remember, intermittent claudication, the pain gets relieved once the patient rests. But in rest pain, as the stenosis increases, there will be pain, or the degree of the PAD increases. Patient will end up in having rest pain, means like they'll get constant pain. Skin may be cold, and it will be pale color. Patient will have dependent rubor. You can see how they are dangling their feet and it turns to red, and then when they elevate it, it turns pale. So make sure do not elevate the extremities. So always try to keep it below the heart level. Uh, then we already talked about pale extremities. The skin may be shiny, dry, loss of hair in the extremity, thickened nails, and ulcerations. Edema, it can be either unilateral or bilateral, relating to the affected extremity. Remember that whenever you do assessment, always do it bilaterally, and simultaneously do it at the same time. Compare both extremity at the same time so you can really see the difference, whether this leg have swelling or not. How about the pulse? Check the pulse to see if it is decreased or absent. Here you can see a picture of how the iliac artery narrowed by a plaque, how it is like really almost closing this vessel, and the patients will have intermittent claudication, or the leg pain occurs on the lower leg. So we looked at we went over the history and physical. We looked at some of the diagnostic tests. We looked at the risk factors and signs and symptoms. Just think about our case study, how this patient really had so many of these risk factors and the signs and symptoms. Then now we're going to look at the treatment. So treatment can be, divided into different ways we can treat the patient. It can be medical management, surgical management. Medical management includes, modification of risk factors like controlled exercise program to improve circulation and um, functional capacity. You really need to have, you really want the patient to have good quality life, so they need to move around as much as possible. So having them to join a walking program or exercise program is very important to improve that circulation, and also their function. Pharmacological therapy, that includes medications. These are the common medications used: pentoxiflin, cyclostatisol, antiplatelet agents like aspirin, and statins. Endovascular management includes some of the radiological interventions, which are common, like balloon angioplasty, stenting, or atherectomy. And these are less invasive than conventional surgery. So we go from less invasive to more invasive. So you can see most of the time the patients are good with, medication management. Their PAD is like treated, but sometimes they may need radiological interventions such as balloon angioplasty or stent placement. Basically, percutaneous transluminal angioplasty. So it's like a catheter is inserted through a vessel, and then it has a deflated balloon, and once it comes to the blocked area, the balloon will inflate. So it pushes that plaque or the um, whatever is blocking. It could be you know fat or plaque, or you know whatever is blocking it, kind of because of the inflammation, it pushes to the side and opens that blood vessel for the blood to flow. Sometimes you know, the plaque may be big, or it may not be able to manage with the balloon angioplasty. The patients may need a stent. Basically, this is left in place. The stent is inserted and it's left in place, so the blood is flowing through the stent. Then in some cases, you know, this the doctor may try it and may not work, then they need surgical management, that is the bypass grafting. Sometimes they may even end up in amputation when there is necrosis, and blood circulation or blood flow cannot be met with the procedures, then they have to amputate. Here you can see the area here is blocked or completely clogged. So then basically doing a bypass, about that clot, about that blockage and to the below the blockage. So there are different kinds of materials used to do the bypassing. Sometimes patients on vessels taken from the other extremity and then sutured about that blockage, and then the blood is diverted through that and then attached to the vessel below the blockage, so the blood circulation is restored. So the bypass, that graft, act as like a bridge that divert the blood flow into the extremity. Um, these are the medical treatment. Now we are going to go into the nursing management. The main goal is to improve the peripheral arterial circulation. Remember, there is a problem with perfusion or circulation. So as nurses, when we take care of the patient, it's very important to manage the patient well to improve the peripheral arterial circulation. This is kind of the main goal, is to restore that circulation. So in order to achieve this goal, we need to do some intervention. So make sure that you position that body part below the level of the heart. So if the legs are affected, make sure that the legs are below the heart. Or if the patient is in the bed, we need to elevate the head of the bed so the extremity is below the heart. If they can sit on the recliner, they can sit on the side of the bed or on the chair, as long as their feet is in that dependent position. That means like dangling the feet. Then assist the patient to with walking, the exercises, again that will improve the circulation. It's important to have some kind of exercise or walking program for the patient, and also encourage patient to walk to the point they feel the pain, and ask them to rest under the pain subsides, and then they restart again. Walk, rest, walk, rest. So that's how they need to do it. So it's there is a chart in your textbook. This is chapter 30. So chart is 30-3, overview of care of patients with peripheral arterial problems. So look at the nursing process. So this, remember, the main goal is to improve the peripheral arterial circulation. The next goal is to promote vasodilation and prevent vascular compression. So in order to improve vasodilation, we want to prevent any exposure to cold, because that can lead into vasoconstriction. Also during the winter time or when it is cold, make sure you encourage patient to wear adequate clothing, keep the temperature warm, protect the patient from chilling. So in the winter time, keep the room warm, have the heat on, have enough clothes when you go outside in the snow, cover completely the feet, the arms, everywhere. um, and patients also should be checking the water temperature when they take shower. So you really don't want them to get burned, right? Because sometimes they may not be feeling the temperature, especially if they have like history of diabetes and they may have peripheral neuropathy. They should not be using, hot water bottles or heating pad on the extremity, but they do. It's okay to apply those heating pad to the abdomen, which will actually cause reflex vasodilation to the extremities. So that is good. So again, remember that it is safe to apply heating pad to the abdomen because it can cause the reflex vasodilation to the extremities. Um, so teach about like smoking cessation, because again we looked at nicotine can lead to vasoconstriction, which we don't want it, and then stress relieving, that is another risk factor. How you can do some stress relieving methods like yoga or walking or whatever works for the patient, and also to prevent vascular compression, avoid any constrictive clothing and accessories, um, tight stockings. So make sure that you teach the patient to avoid any of these things. And a common practice many people do is like crossing legs. That should be avoided. Again, it can lead into vascular compression. The next goal is relieving pain and maintaining skin integrity. So patients will have pain and patient may have impaired skin integrity. So it's important to relieve the pain and maintain skin integrity. So for pain, you can encourage patient to use analgesics. So again, depends on the level of the pain. Sometimes they may have to use opioids. um, Advise patient to avoid any trauma to the extremity, so they need to wear protective shoes, good skin care to especially to the to foot care and meticulous skin care. They can use like mild soap. When they wash their foot, make sure they wash, dry it, no lotion between the toes, because that can lead to maceration or overhydration or fungal infection. And they need to monitor the foot, like bottom of the feet every day. If there is any opening or any abnormality, they need to go to the doctor immediately, because once there is a problem, it can really um, it can lead into amputation, because it can just make it so complicated. The patient may get a wound and it gets bigger, and circulation is impaired. The wound won't heal, and then they may get infection and end up in amputation. So it's very important to have good skin and foot care, wearing protective shoes, no sandals. They need to really cover the foot, and correct size. They should not be wearing some tight shoes and get blisters and then wound. Good nutrition is important, like high protein, vitamins, and whenever you educate patient, make sure give them verbal and written instructions, and include the caregiver whenever you give education to the patient. Sometimes they may not retain everything, so it's important to include the caregiver. So back to our case study. Remember Miss Smith, right? So I put the case study here, just had to remember her story, and then uh, you know look at what where her modifiable risk factors, you know, for her to develop PAD. So remember, she was smoking 10 to 15 cigarettes per day. That is, cigarette smoking is a big risk factor. Um, so even though she has hypertension and hyperlipidemia, cigarette smoking is, a big, most not notable modifiable risk factor. Um, so all the risk factors promote the development of arteriosclerosis and require pharmacological treatment or lifestyle modification. So, um, smoking cessation is the crucial risk factor for this patient, like modifiable risk factor. So, lifestyle change is very important. Um, as we are going to review the peripheral arterial occlusive disease. Um, Again, arterial insufficiency affects the lower extremity than the upper extremities. Um, Distal occlusive disease more frequently seen in patients with diabetes and older patients. There may be occlusion in the artery, and it can, below that occlusion, the circulation can be completely gone. So the hallmark symptom for PAOD also is intermittent claudication, like achy, crampy pain, then or induced fatigue or weakness. It can happen with some exercise or activity and relieves with rest. Remember, it relieves with rest, the intermittent claudication, but as the ischemia or the vessels get narrowed, the pain associated with the critical ischemia of the distal extremity, the pain can be persistent aching or a boring pain. So it's like non-stop pain. It's called rest pain. So they have it, persistent pain. It's not going away, it's there. Ischemic rest pain is usually worse at night and often wakes up the patient. So just remember, when patients lay down, they're kind of laying flat. It's not really like may not be like below the heart level. So when they go to bed, they may fall asleep and then they get up with the pain. So they have to really, get up and put their, dangle their um, feet, and then they will feel better. Sometimes patient may sleep on a recliner just to keep the heart, extremities below the heart. What are some of the assessment and diagnosis? So assessment finding is basically same as we described earlier, cold, there may be numbness, remember the 6 P's, the pain, paresthesia, pallor, pulses, and then paralysis. Patient may have intermittent claudication, like the pain, the cool, temperature, pale, the extremity turns pale when you elevate it, and kind of reddish color on the dependent position. Skin and the nail changes, we looked at already. Then unequal or absent of normally palpable pulse. This is significant because this is occlusive disease where there was pulse and suddenly there is no pulse. Sometimes it happens, especially after bypass surgery, like femoral bypass surgery. The surgery is done to correct that, occlusion or the narrowing or stenosis. Once the patient comes to you after surgery, the pulses may be, restored, the circulation is restored, and you monitor the patient very frequently, especially in the beginning of the like immediate post-op. So for example, if you palpate the pulse at 1 p.m. and um, 1:30 you go there and palpate the pulse and it's not there, that is like a big change. So there is like a, that's where there is the absence of normally palpable pulse. So you really need to call the doctor, the surgeon immediately, because sometimes there may be a clot that traveled and then block that, artery. They may have to take the patient back and reopen and then, remove that clot. So it's very important to monitor the patient. Then assessment also includes a history and physical diagnostic tests like, Doppler, ABI, duplex, and imaging studies. Um, Pharmacological therapy, again, these are common medications. Please review this medication in your pharmacology book. Review the assigned chapter for this class in your pharmacology book. The common one again, the Trentol, the Platol, aspirin, Plavix, statins. So the important, what it really does is like used is like the Trentol and the Platol, they are used for symptomatic claudication because these medication dilates the vessels. So the patient feel better when you have that vasodilation, the blood can flow and the patient feels better. Then these are antiplatelets to prevent thromboemboli or the clots. Then statins are to improve the endothelial function. Medical management, we talked about an exercise program earlier, walking program, if they are obese, weight reduction, smoking cessation. So there's a lot of, um, you know, these are like, behavioral changes they can do. Endovascular management, we looked at balloon angioplasty, stent placement, stent graft, atherectomy. So surgical management includes endarterectomy, femoral to popliteal graft. So this is a picture of aortoiliac endarterectomy. So there is, plaque or like the fat is identified. So there's, clamps are there applied to, prevent that blood flow. So you can make that incision and remove that plaque. And then once the plaque is removed, it is sutured back. So then the blood flow will be restored. Nursing process, which includes the assessment. Always take the health history and the medications, look at the risk factors, signs and symptoms, especially claudication, rest pain, color changes of the skin, the pulses, are they there, weak or absent, skin changes, skin breakdown. So these are the main parts of your assessment. Then once you complete your assessment, you can come up with a diagnosis, nursing diagnosis. So it can be altered tissue perfusion, chronic pain, risk for impaired skin integrity, knowledge deficit. These are like very common nursing diagnoses for these type of patients. Planning. So the major goals include increase arterial blood supply. You really want to restore that blood supply, promotion of vasodilation and prevention of vascular compression, and self-care program. It's so important to have that, adherence, complying with the self-care program. Then how can we meet these goals? We need to do some interventions. So exercise and activities, we talked about walking, greater isometric exercise. Again, remember we need to have a prescription or order from the physician what kind of exercise program may be safe for the patient. If they have like critical ischemia, the patient may not be even a candidate for exercise program. So make sure that consult with the primary care physician or the provider before exercise program. Positioning, arterial condition, lower the extremity below the heart level to enhance the arterial blood supply, avoid crossing, no standing or sitting for too long, avoid constricted clothing, temperature, maintain warm temperature to prevent vasoconstriction, stop smoking to prevent vasoconstriction again, smoking cessation program, stress reduction, again, to prevent vasoconstriction, administer medications like vasodilators and analgesics for pain, avoid any trauma, good skincare, protective shoes. We already talked about all this, good nutrition and weight management. So all this is very important, and you can see in chart 30-3. Sometimes these patients will have surgery like femoral popliteal bypass graft surgery. So how do you take care of them post-op? The main goal again is like the primary objective is to maintain circulation, because the patient had surgery to restore that circulation. We want as nurses, we need to make sure that we maintain that circulation. So checking the pulses, use the Doppler. Most of the time you may have to really use the Doppler to assess the pulse. Check the color, the temperature, the capillary refill, sensory and motor function of the affected extremity compared with the other extremity. Always remember that when you do this assessment, compare with the unaffected or the other extremity. ABI is monitored at least every 8 hours for the first 24 hours, then once a day. That is very important. All this is very important. And notify the surgeon immediately with the disappearance of a pulse that was present. We talked about it. Then monitor and manage potential complications. So this is a major surgery the patient may have, and they are at risk of getting hemorrhage. Monitor their intake and output, make sure there is a balance of intake and output. Vendor status, vital signs, these are like, frequent monitoring is very important, because this will give, if they have any potential complications. Interventions, again, monitor for signs of thrombosis distal to the surgical site. So if there is a thrombosis, then you may lose the pulse on that extremity, maybe the skin. You will see all these signs, like check the neurovascular status on the affected extremity. The 5 P's, like the pain, how is the pain, pulse, the pallor, paresthesia, can you feel me, paralysis, can you move? So monitor vital signs, pain, intake and output, lab results. You may have to do frequent labs. They may be on some medications to prevent clotting. Inspect the surgical area for any infection or bleeding, administer IV fluid, perform physical assessment for any, monitor for any possible complications, any signs of hemorrhage. Give pain medication is important, manage their pain, early ambulation, earlier the better. Again, you need an order from the physician to ambulate the patient. Safety measures to prevent injury to the surgical site. So when you think about like femoral popliteal bypass graft, it's a long incision, so really protect that extremity from any injury. Now we're going to look at venous disorders. So now the problem is venous blood flow. So we were looking at arterial blood flow, now it is venous blood flow. So venous thromboembolism, includes both deep vein thrombosis or DVT and PE or pulmonary embolism that happens in the lungs. So deep vein thrombosis is in the deep veins of the extremities. Most of the time it is the lower extremity, but it can happen on the upper extremity too. A clot from the deep vein can travel to the lungs and the patient will develop pulmonary embolism. So both of these conditions are called the venous thromboembolism, chronic venous insufficiency, or post-thrombotic syndrome. So that also is a type of venous disorder. So post-thrombotic syndrome has like chronic venous stasis, so the blood is like staying on the lower extremity. That will lead to edema and altered pigmentation. There may be leakage of like blood, and the skin will turn to kind of brownish color. Patient will have pain. The skin will have like dermatitis. Other venous disorders include leg ulcers, varicose veins. You can see like different stages of the varicose veins. What is a normal blood flow? The venous problem is like there is blood going in, there is no arterial problem, there is blood flow. The problem is the blood to go back to the right side of the heart, like the veins have problem that it cannot carry the blood adequately into the heart. So these valves, these are normal valves. Here you can see there is damaged, deformed, open valves here. So it can do kind of reverse blood flow. The veins are kind of dilated. It is inflamed. So the walls are thinner. So you can see a lot of problems here. The venous thromboembolism, the pathophysiology, there's really no one reason or risk factor. It can be, different risk factors that can be divided into three. That is the Verco's triad that includes like three main risk factors that can lead to venous thromboembolism. So endothelial damage. So on the right side you see a table with examples of endothelial damage. Whenever the patient have any trauma or surgery, there is damage to the endothelium. Central venous catheter, you will see patients getting DVT of the upper extremity mainly whenever they have central venous catheters to the upper extremity. Then the venous stasis, that can happen whenever a patient is in the bed. There is no, the blood flow is impaired because all the blood is kind of pooled to the extremity. They can definitely, develop DVT for, whenever they are on bed rest or they are immobilized for a longer time. Obesity, history of varicosities, then altered coagulation. So it could be any coagulation problems, pregnancy, cancer, oral contraceptive use, protein C deficiency. So any of these factors can put the patient at risk of getting a blood clot. So whenever patients have any of these things, they are really at higher risk of getting a DVT. The more risk factors, the higher chances. So the VTE or venous thromboembolism can happen to deep veins, superficial veins. There's a YouTube video you can watch. Then clinical manifestations or signs and symptoms when it happens to the deep veins. There will be edema to the extremity. You can see there's a blood clot there, so you can see like edema of that extremity. Patients will have, pain. There will be like kind of, feels affected extremity may feel warmer because of that inflammation. There will be pain. There may be like superficial, veins can be noticeable. If the blood clot dislodge or move or come out, or it can just detach from the blood vessel and then travel along with the blood flow, then it can go into the right side of the heart, the right atrium, into the right ventricle, into the pulmonary artery, into the lungs. So it can get stuck in the lungs and they can have a embolism in the lungs, which is called the pulmonary embolism. And comparing to the superficial veins, you can see, may have pain, redness, and warmth. Okay. Prevention, how can we prevent, VTE or venous thromboembolism? Apply the graduated compression stockings. That's very important, and then it kind of helps to prevent that swelling and pulling that venous stasis or that um, extra fluid, the swelling, and to reduce use of the intermittent compression device. Here it is like a pump that kind of use like that calf muscle, pumping the blood back to the heart. Early ambulation and leg exercise is very important, so really encourage patients to walk. Administer heparin, like pharmacological management include subcutaneous injection of low molecular weight heparin and unfractionated heparin, especially in patients with post-surgical patients. Lifestyle changes like weight loss management, smoking cessation, and regular exercise. Again, the main objective for treatment for DVT is to prevent the thrombus from growing and fragmenting, recurrence, and post-thrombotic syndrome. This is the main objective for treatment for DVT. How do we manage it? Pharmacologically, giving unfractionated heparin, low molecular weight heparin like enoxaparin or Lovenox, or anticoagulants like warfarin, factor Xa inhibitors, and thrombolytic therapy. These are examples. Please review your pharmacology chapter in your pharmacological book, and also in the MedSurg book on chapter 30, contraindications to anticoagulant therapy. Review the pharmacological management in depth. It's very important to review that. What are the medications? What are the actions and contraindications? Please review it. And the next slide actually have some of the medications, major indications, and the adverse effects. So like the heparin, major indication is anticoagulations in patients with current VT or VT prophylaxis in patients with who are at higher risk. So review this. What are some of the adverse effects? Management again, we looked at, different management. Now we are looking at endovascular management. In case if, when the anticoagulant or thrombolytic agents are contraindicated, that's when endovascular management is done, and also in danger of PE, then we need to have endovascular management and severe venous compromise. Then we do thrombectomy, ultrasound assisted thrombolysis, vena cava filter, balloon angioplasty with stent placement. This is a picture of vena cava filter. So a filter, it's like an umbrella, so it basically filters any blood clot from going up towards the lungs or heart or brain to any of the vital organs. So it kind of filters these days in the patients. You will see these patients with vena cava filter, or if it is inferior vena cava, it's called IVC filter, inferior vena cava filter. For those patients who are, are risk or bleeding, who cannot get anticoagulant or thrombolytic agent, then they need, you know, these filters. Nursing management include assessing and monitoring of anticoagulant therapy. Activate a PTT or APTT, PTINR, hemoglobin, hematocrit, platelet count, fibrinogen level, So it's important to assess and monitor patients when they are getting this anticoagulant therapy. And also monitoring for potential complication. Main complication is bleeding, because the anticoagulants can be dangerous, and that's why you have to really monitor the PTINR or APTT, hemoglobin, hematocrit, the platelets count, to make sure that they don't go into bleeding or thrombocytopenia or platelet drug interactions. Other nursing management, as nurses, we need to make sure that we provide comfort, compression therapy, positioning on the body, and encouraging exercise. So patient education is in chart 30-10 on how taking anticoagulant medication. So it's very important to educate patients when they are on anticoagulant. Review the chart 30-10. This is a small box here having the information on PT and INR, that prothrombin time, and the international normalized ratio is a standardized measure of degree to which the patient's blood coagulability has been reduced by the drug. So most of the time the INR, a normal INR, is between 2 to 3 to 2 to 3.5. Again, it depends on the indication or the indication for use of the drug. So it can be given for DVT, or it can be given when somebody have a valve, like artificial mitral valve, so to prevent any clotting. So it's important to know what is the therapeutic INR for your patient, and monitoring the labs, and calling the doctor to adjust the medication is very important. Otherwise the patient can go under either to bleeding, or they can get blood clot. Next one is about leg ulcers. So the ulcers, it's a stabilization of the skin surface, occurs when it is inflamed. Necrotic tissue gets sloughed off. You can see this is the necrotic area. So ulcers resulting from arteria emboli. So you can see the extremities are not getting the blood supply. There is no oxygen. So it turns blue, is cyanotic. Then it turns to be like, gangrenous. There is severe ischemia. Then this is a venous stasis ulcer. So you can see that it's red. It's, there is blood supply, but this is the problem, is like, blood returning to the heart with the venous disease. comparing venous and arterial ulcers, characteristics of arterial ulcer and the venous ulcer. Please review this chart. It's very important how you can differentiate whether it is arterial or venous ulcer. Look at the location. If you see on the tip of the toes or toe webs, heels, or other pressure areas, that it, when patient is confined to bed, it may be on the pressure area like the heel, or it could be like to the scapula or wherever it is. It can be very painful when you think about like pain, where the venous also the location is different. It's most of the time medial malleolus, lateral malleolus, anterior tibia area. Minimal pain. It can be achy pain. Depth of the also it can be deep. But venous is superficial. Shape is circular, and arteria is kind of a punched out kind of a shape, really circular, but here it is irregular. Base of the ulcer is usually pale. Remember, there is no blood supply, but here you can see it's kind of granulation tissue, beefy red. But it has a lot of exudate, or it's like a lot of drainage coming through here. Remember, it's like patient have like swelling, there is fluid collection, edema, but here it is dry gangrene. And maybe there is not, it may be just dry. Edema, maybe minimum, unless extremity kept in dependent position. If we keep the leg in the dependent position, it may have more edema. For venous, it is a lot of edema, like moderate to severe edema. Nursing process, again, we can see baseline in 8 weeks. This is the condition, 18 weeks. It takes forever to get healed. So assessment, history and physical, assess the pain, temperature, pulses, edema, mobility, nutrition, past medical history, diabetes, varicose veins. Then the goals is to restore the skin integrity, improve physical mobility, and provide adequate nutrition and absence of complications. So what are the interventions I can do? Restore the skin integrity, wound care, position the legs in the dependent position. Position, legs depends on also origin, whether it is arterial, then you kind of lower the leg, venous, you have to elevate. Avoid trauma to that extremity, improve physical mobility, restrict activities in acute phase, then encourage mobility and manage pain so they can walk. Promote adequate nutrition, provide high protein, vitamin C, A, iron and zinc. Educate patient and family on diet. After the assessment, the nursing process comes the diagnosis. So these are the possible nursing diagnoses. So assessment, diagnosis, your planning or goal, then nursing intervention, then evaluation. You're evaluating that goals. Here it says demonstrate restored skin, increase physical mobility, and then attain adequate nutrition. Now we're going to look at varicose veins. So varicose veins are abnormally dilated, enlarged, and twisted veins, most commonly appearing in the lower extremity. You must have seen patients or people outside there, especially in the summer, you may be able to see some varicose veins on these people. So patients, the signs and symptoms, you can see the normal, here how the valves are open and there's normal blood flow. So the blood is flowing against gravity. When there is problem with these valves in the vein, the blood cannot move as normal. This one here, it's like, it's going upwards and backwards. There is a problem with the blood movement. The patients may complain about dull ache, muscle cramps, fatigue of the lower extremity, ankle edema, feeling heaviness, nocturnal cramps or like cramps at night. Then diagnostic test is through duplex ultrasound scan. Varicose veins again, how we can manage or prevent avoid activities that cause venous stasis, like wearing socks that are too tight at the top, or tight top that can leave marks on the skin, crossing legs at the thighs, sitting or standing for a long period. So avoid any activities that can cause venous stasis. Then change positions frequently, elevate the legs 3 to 6 inches higher than heart level. It's very important, and encourage patients to walk 30 minutes each day if there is no contraindication. Wear graduated compression stockings, very important. Overweight patients should be encouraged to begin weight loss program, so it's very important. Medical management includes surgical ligation and stripping. Usually it is done like outpatient clinic or vein clinic, thermoablation, sclerotherapy. Nursing management of patients after this procedure includes encourage ambulation, compression therapy, elevate foot of the bed, then manage pain management. They will have pain, monitor for bleeding, and tracings of the surgical site. That is the end of the PowerPoint. I will see you in the class. Let me know if you have any questions. Thank you. Hello everyone. This is Professor George. Today we are going to be learning about assessment and management of patients with alterations in perfusion. So we are going to be looking at patients with different kinds of alterations and perfusions, mainly peripheral vascular disease. So peripheral vascular disease, it can mainly affect the peripheral um, peripheral arteries and the veins. That is mainly the upper extremities and the lower extremity. So peripheral vascular disease is a leading health concern in the United States with an estimated prevalence of 8.5 million people. So the PVD incidence is growing due to increasing rates of obesity and diabetes, as well as aging population. Um, so, as I said earlier, peripheral vascular disease is categorized as either venous, arterial, or mixed. So, a different assessment is essential to identify the type of PVD and to plan management strategies to prevent further vascular dysfunction. Um, this is really getting common as we have aging population and patients with obesity and diabetes. This is actually a big risk. These are the big risk factors for PVD. Like the minimum cost to treat for PVD on a yearly basis for one patient is about $7,000. So peripheral vascular disease is actually uncommon in patients under 50 years of age, but it increases its prevalence with age, and definitely as they get older, the risk factors or the prevalence goes up. Most of the time, you may see these patients in the nursing home or assisted living or in home care situations. Definitely, you will see these patients in the hospitals too. So again, vascular disease is either venous, arterial, or mixed. Definitely the assessment is different for both. So once we come up with the assessment and diagnosis. We can treat the patient, depends on the cause, either venous or arterial. Venous disease is more common in females and older adults, and also those with family history. These are the topic outcomes. So we'll be going through a brief explanation of anatomy and physiology of the peripheral blood flow and tissue oxygenation. We'll be looking at different diseases that affect arteries and veins, including clinical manifestations, diagnostic tests, risk factors, management, both medical and nursing, and also how to prevent these diseases. Most common venous disease includes like DVT. Then we'll be looking at peripheral arterial diseases and how to manage them through medical treatment, also nursing management. We'll be including nursing process to understand the nursing care of these patients with different venous and arterial diseases. As nurses, we will be taking care of these patients when they come to us, and we need to know really what is it, which one is it arterial or venous, and depends on that, the care will be different. So we'll be going in depth about different diseases and how it can be managed. Please review these topic outcomes. Each one is important. Here, this is a brief anatomic and physiology overview. So it's important to have adequate perfusion, which actually helps with oxygenation and nourishment of the body tissue. So perfusion is important, so the blood can carry the oxygen and the nourishment to the body to keep it alive and functioning. Again, the perfusion, adequate perfusion depends on the part, depends in part on a properly functioning cardiovascular system. So it's important to have a properly or normally functioning cardiovascular system to have adequate perfusion. So again, here you can see the adequate blood flow or the perfusion depends on the efficiency of the heart, how well the pump can, the heart can pump. So sometimes because of certain problems with the heart, the pumping function of the heart may be slow or weak. As in congestive heart failure, the heart may be weak, so then it will affect the blood flow. So in order to have good blood flow, we need to have good pumping action of the heart, and also patent and responsive blood vessels. So blood vessels should be patent, meaning it should be open for the blood to flow freely. And have enough blood or adequate circulating blood volume is needed to have that adequate blood flow. Some of the factors that affect the rate and adequacy of the blood flow now depends on the nervous system activity, the blood viscosity, the metabolic needs of the tissue. So this is a brief overview of the anatomy and physiology of the vascular system. Now we are going to actually look into the vascular system itself. The right side of the heart, the left side of the heart, the arteries and the veins. Here you can see the right side of the heart. It pumps the blood through lungs and into the pulmonary system. So the blood comes um, to the right atrium, then it goes to the right ventricle, into the pulmonary artery, and into the lungs. Then you can see the left side of the heart where the blood is pumped. It gets into the pulmonary, the left pulmonary veins, bring the oxygenated blood into the left atrium to the left ventricle. Then it goes into the um, aorta, and then it is supplied to the body parts. So or the deoxygenated, though, that is going to be the oxygenated blood that is on the left side of the heart, that is supplied throughout the body. That is what is circulating in the body system. And the deoxygenated blood, that is something that is coming to the heart and into the lungs to get oxygenated. The arteries carry the oxygenated blood, and the veins carry the deoxygenated blood. Here you can see the cross section of the vein and the artery. So artery, the blood is flowing freely to the body. Then if there is problem to the peripheral vascular system, then the